Welcome, everyone. Good morning, good afternoon, and perhaps for some of you, good evening and good night. Welcome to the 2021 OncTalk by Grace, the global resource for advancing cancer education. My name is Dr. Abi Degogo-Jack. I'm a thoracic oncologist at Mass General Hospital. And I think that we have a very exciting program ahead of us. And we're very grateful that you took time out of your day to join us and to learn from some of what we consider the leading thoracic oncologist or the leading oncologist in lung cancer. We're very grateful to these oncologists for also taking time out of their Saturday to impart knowledge and to teach us. I also want to acknowledge our sponsor of today's event, Takeda. And as far as a rundown of the program and the format of today's program, we will have two panels, and these will span subjects ranging from early stage lung cancer to more advanced lung cancer. We think that the subjects and the topics are pertinent and very relevant to our current practice, but we also have a component for a Q&A section. In this session, we really encourage you, and pretty much throughout the program, to please submit questions using the Q&A button at the bottom of your screen. And we very much look forward to answering these questions. Our first panel is on early stage lung cancer, and it'll be led by my co-moderator, who I would argue needs no introduction, but I will introduce him. This is Dr. Jack West. He is the founder and CEO of GRACE, and he's an associate clinical professor of medical oncology at the City of Hope Comprehensive Cancer Center. And with that, Jack, I will turn things over to you to kick things off.
Well, thank you very much. I really appreciate your being here and sharing this. It's great. And I'll actually, if I can, I'll have you just turn off your video for now, and we'll have the four of us on this panel for this. And I would, at this point, like to ask our my panelists for this to introduce themselves, however, your current best titles are and what you think is most relevant for our audience. Maybe if I can start with you, NJ, if you can tell us about yourself, and we'll work around the horn.
Hi, everyone. I'm Dr. Narjust Duma. I'm the Associate Director of Cancer Care Equity at Dana-Farber and a medical oncologist. And I have a particular interest in younger women with lung cancer. And I'm delighted to be here with
I'll go ahead and introduce myself. I see it frozen on my end. I'm Dr. Estella Rodriguez. I'm co-lead of the Thoracic Side Disease Group at the University of Miami Sylvester Cancer Center. And I also am Associate Director for Community Outreach. And I have been involved in prior educational programs from GRACE. And thank you so much for the invitation. It's a great opportunity for us to connect with you.
Perhaps I should introduce myself. My name is Riyaz Shah. I'm a consultant medical oncologist in the United Kingdom, based in Maidstone, Kent, which is basically the southeast of the UK, nearest France.
Hi, folks. Hopefully you can see and hear me now. And I apologize that this was my worst fear realized, that my internet would not work well on this moment. But I'm on a different computer, and this one has a hard wire, so let's go for it. I don't know where we left off. Last I saw, I had invited Dr. Rodriguez to introduce herself. If we could.
That was done.
Oh, good. Okay. Can I just ask you, do you prefer, we're going to use first names. Can we do,
my name is Estella,
okay.
Short name. So you can call me Estella.
And Riyaz, if you can speak. Did you do yours too?
Yes, I did.
Okay.
And I'm Riyaz.
Okay, good, excellent. So let's start with, I think one of the most interesting things that has happened in the field of lung cancer in the last year or two has been really an explosion in in early stage disease. And for years, all of our progress was in patients with more advanced disease, and we really had old standards that didn't change for decades. And now we have a lot of new changes. Let's start with just the question of molecular marker testing. Molecular oncology changed our field 15 years ago or so, and it's continuing to evolve. It needs work, but that has mostly been restricted to advanced disease. I wanted to know what your personal practices are today. What do you think is evidence-based, and what is your personal and institutional practices for molecular marker testing for patients with resectable disease and for patients with locally advanced disease. Anybody, if you can just start with your practices. And Riyaz, if you can, I know that, you know, that the situation may, I don't know how much there's a countrywide policy, so you can speak to whatever you think is the prevalent patterns. But Estella, were you speaking?
No, but I will take the answer. So we did not do any reflex testing in early stage disease because there was no targeted therapy options until the Adara publication of osimertinib. And now we only do reflex testing for PD-L1 so that any patient that has surgery or a biopsy, we know the PD-L1. And then when the patient gets seen by an oncologist, the oncologist can decide what panel, but most of us do a full sequencing now on those patients that get referred. But I recently reviewed our data, and obviously we don't meet every patient that comes through the institution. So who orders a test, if it's not reflex testing, makes a big difference. But right now I will say most of my colleagues at the University of Miami, when they meet those patients, they will order an NGS.
Riyaz, what's your practice there?
So, I mean, that's actually a really interesting question. In the UK, we have nationally driven targets to start patients who are diagnosed as quickly as possible on systemic therapy. And we have every center treating lung cancer has a weekly, you would call it a tumor board, an MDT meeting is how we would term it. And we are very keen to reduce weights, unnecessary weights for tests. And one of the most pragmatic decisions that many centers, certainly where I work, have made is that the pathologist, when they look under the microscope at a biopsy and diagnose lung cancer, isn't necessarily aware of the full staging where that patient is in the pathway, right? So if they wait for that tumor board to happen and for that decision to be made and then molecular testing to be initiated, that could easily be a 1 to 2 week wait, additional delay onto the pathway. So we have a fairly straight system of reflex testing, even though I agree it's not entirely necessary for early stage lung cancer. I mean, we will basically look for PD-L1 and EGFR to be done because those are the areas, those are the two key markers that will affect early stage disease treatment patterns. But the reality is most of the patients that I treat who've had unless they've gone straight to surgery, who've had some sort of investigational biopsy in their pathway will have had quite comprehensive molecular testing routinely and reflexly.
And that's even for a stage 1 candidate.
So, well, the pathology department would not know that that is a stage 1 case. So yes.
Okay. And NJ, what are things like? Do you have a clear sense? I know you haven't been there a long time, but what's your sense of things in Boston or where you had previously been?
So there is take into account that I used to have a clinic that was mostly dominant. This means how we sequence all of them because they are a different type of population, younger women, and we allow them to determine which treatment is better. But as a general perception, I do molecular testing to identify if the patient will be a candidate for any of the neoadjuvant or adjuvant trials we have at Harvard. So that allows, right, if the patient has a mutation, the patient can go in the red adjuvant trial, you can go in the directed therapy. So I have done sequencing for early stage, mostly stage 2 and 3, to identify if any of these trials are a good option for them. And we do our next gene sequencing or onco panel, so the turnaround is around 2 weeks. So we have that, extra fast, like it gets faster to us. But I do sequencing to determine if they would benefit from clinical trials.
No, I'm afraid we've lost her. We may try to get her back in if we can. I apologize that the connection is not that clear, but she did bring up the issue of differences by stage. One thing that the pathologists do have is histology, and whether it's squamous or non-squamous, what are your views about level of enthusiasm or data to support, you know, a difference in the mandate or desire for molecular testing for squamous or non-squamous, trying to be both comprehensive and efficient, parsimonious? Riyaz, can you take that first?
So until fairly recently, PD-L1 testing is pretty much all we would do for a squamous patient. And then if I met that patient in clinic and they turned out to be the occasional non-smoker, then I would personally get back to my pathology lab and ask them to do a full genomic screen. And then we would routinely do full genomics on non-squamous. But I think the KRAS thing has really made me rethink that. So sotorasib and G12C and picking up all those patients. So I mean, we haven't switched to doing full molecular testing in squames yet, but I'm really having a hard think about it.
And there's no kind of healthcare-wide policy on that.
No. I mean, we don't have to. I don't have to fight with individual insurers. I think as a nation, we have to fight with the central commissioning system, and once that is approved, then it's you know, uniform in theory.
And Estella?
Yeah, I would add that, you know, as we're doing more next generation sequencing and really understanding co-mutations and a lot of different things that happen when these tumors present, obviously we know that when patients have resected disease, that tumor may be very different than when they have metastatic disease where KRAS G12C and MET exon 14 skip mutation can have an option for squamous. But I have found it useful that when we have NGS analysis on patients with squamous, and we found co-mutations like KRAS, STK11, KEAP1, it kind of raises the concern of follow-up for that patient. So I have kind of taken that into part of the story of that patient. But I think we know that there's some mixed histology, so we don't really try to base the test on the histology since we can find some EGFR mutations on tumors that have mixed histology. So we are trying to not base it on histology, just really understand the pathology and the genomics for that patient.
Okay, great. And Narjust, I see you joined again. I hope.
Sorry, I'm in like the northern part of the state, and it looks like the internet is not great here.
Fair enough. Well, we were just, you know, basically following up on, you had mentioned in your answer that there's differences based on whether it's stage 1 or 2 and 3. If you can speak, I didn't catch it that clearly. Maybe you can speak to both your personal level of enthusiasm or disinclination for broad testing based on stage, and also whether histology and squamous versus non-squamous is much of a factor to you, or is it a broad, everyone gets everything?
Well, I think to tend to be a little more histology. Can you hear me, Jack? Better?
Very well.
So third time is a charm. I think we divide between adenocarcinoma and squamous, in part because how we're gonna get these tests also covered by insurance. Because for early stage has been a little bit more challenging to get it covered, or patients have big copays and there is no option of doing plasma because these are early stages. So that helps me differentiate if the patient will go into the billable NGS or we go into a research NGS protocol, that those patients won't get charged. It's under a research protocol. So, you know, besides the histology, it's also the reimbursement. It plays a role in these cases. We also have patients that come as second opinion, so they already come with some genetic testing in some cases. But the main reason why I do it is to determine if they are candidates for trials and start planning ahead of time. Because I would hate to have a patient that has an EGFR mutation and go in an adjuvant immunotherapy trial. I know Power 0110 included those patients and the approval includes them, but we know that immunotherapy is not great for those patients. So I don't want to go in the wrong trial. I also like to prepare things ahead of time. So I don't preclude the possibility of the patient of going in an adjuvant trial. For example, 38-year-old patient I have, we did NGS and she has a RET mutation. So I'm able to like pre-screen her for the trial as she gets ready for surgery, and we all work together so nothing is done to exclude her from the trial. because I have been in the case in which the patient comes after the surgery and you're like, oh, but we needed to do all of this. And then the patient cannot enroll in the trial. So just planning like 3 months ahead of time, NGS allows me to do that.
Right. And I wanted to, forgive me if you mentioned it, all of you, I didn't quite understand or hear about, for a patient with locally advanced disease, not a surgery candidate, but chemo radiation, are you doing broad testing? My sense is a lot of people are. It doesn't necessarily matter squamous or non-squamous when you're in stage 3 and not a surgery candidate. The decision of whether to consider a targeted therapy or specifically durvalumab immunotherapy as consolidation, it isn't an explicit standard of care to do this. But what are your practices? Estella, can I start with you in terms of what the practice is for stage 3 unresectable in terms of broader molecular testing and why?
So we were part of the Pacific trial, and I think that trial didn't require testing, and we were basically consolidating everybody with immunotherapy until more data comes back, and really the long-term follow-up of that trial shows that the patients with EGFR mutation don't really benefit from immunotherapy, like we've seen this message in many other trials. So I want to identify these patients because I would hate for them to have a long-term complication from immunotherapy or progress in the middle of that year of consolidation that is very expensive also and involved. I mean, the treatment used to be every 2 weeks, now it's every 4 weeks, so durvalumab. So I think it's important to identify these patients early because I think you could change the treatment or not even offer immunotherapy. I have a discussion with patients about that. Their immunotherapy is what we think can help after radiation for locally advanced unresectable disease, but it may be that your particular case will not respond to immunotherapy. And then we'll decide together, but it's hard to get, osimertinib consolidation after chemo rad. So what else can you do? Right.
What about the issue? I'm just going to ask for everyone. I suspect that there's relatively little enthusiasm for giving durvalumab for someone with a known EGFR mutation. Is that
yeah.
true? I mean, even though they're in the trial, and this is, I think, an important broad issue for us because we, I think, are carving out more patients in subgroups based on biologically relevant differences, like saying, well, this patient may have been enrolled in a trial like Pacific, but I don't think it would be a good idea. And Estella, one of the other points that in addition to cost, we would be concerned about someone being on durvalumab immunotherapy and progressing and then needing to go into an EGFR inhibitor, especially osimertinib, where Tagrisso, and we can use the marketed names for our patient audience that's familiar to them. There's a real risk of pneumonitis that we would be concerned about. So that's one more disincentive. But what about PD-L1 and Riyaz? I'll start with you about in Europe the use of Imfinzi is gated by positive PD-L1. That's not the case in the US. Is that something that you or others kind of wish was broader, or the data are not very strong for those with PD-L1 negative? So I would say that at least many oncologists in the US are unenthusiastic about it. What's your take on this? And is this something that you're very, very comfortable with that restriction?
I mean, this is really a very, very interesting area, I think, and it highlights the differences in licensing, regulatory approval, and how that can influence clinician behavior. So it would be really interesting to know in the US how many oncologists give adjuvant durvalumab to PD-L1 negative patients. It's not an option in Europe. It's not an option in the UK. Our approval in flimsy, it's very much PD-L1 positive. When I look at the data, in fact, before this meeting, I was just having a look at those hazard ratios again, and I walk away from that data very comfortable with it not being an option in PD-L1 negative patients. I look at the data and it doesn't look like it does anything meaningful to me. But if I worked in an environment where it was approved in that setting, that would be a subliminal pressure for me to prescribe a treatment. In my heart of hearts, I may not feel it does very much, but if a patient and a family are coming up to me saying, "Hey, what are you doing? Why aren't you giving me this drug in, even though I'm PD-L1 negative, it's approved." It would be a difficult conversation. So in many ways, I'm quite thankful that the EMA, the European regulatory authorities, have taken away that struggle for me and made it quite easy. But I would. Yeah.
What I think is really interesting, Narjust, I'd love your perspective as well, and Estella. I had previously had a mindset that if patients were in part of a trial, the trial is extremely positive, the approval is there, you do it. Narjust is now in Boston, and several people who are, global experts in EGFR and think about it all day long, are vociferous against giving this to patients with EGFR mutations, and my own view about low PD-L1 or specifically negative PD-L1 has evolved over time, seeing some of the curves that you alluded to, that the patients with negative PD-L1 don't seem to benefit. And so once you get into the mindset of just because it's approved doesn't mean you should do it, and I would argue that the FDA now has an approach that is very liberal. They're not taking the responsibility. They don't mean to imply that you should do everything they approve. They just want to pass it on to the decision of the physician. So that's my sense, but that means that it's incumbent on the physician to be judicious or thoughtful about this and not reflexive that FDA approved means give it. Narjust, what's your view here? And then I'll turn to you, Estella.
I think what we all have to, see is lung cancer as a very heterogeneous disease. Like, while we compare to breast cancer, when you have hormonal receptor positive, HER2 positive, they're seen as completely different diseases.
Right.
And that's how we have to see lung cancer. It's no longer a disease of small cell and no small cell. It's at the molecular level. And even in the molecular level now, it's marrying for like all positive disease. We know the types of cell clones really makes a difference now. So we're getting to a level that's so granular that we need to see the disease as many different types of disease. For consolidation with durvalumab, with EGFR positive mutations, I have a good conversation with patients. The majority of patients do not go in the consolidated therapy. But being a referred center also means that the patients go back home, and sometimes they're started therapy by their oncologist. But I have been in the position, Jack, and when one of my patients had disease progression, and it was an EGFR positive, and then the tumor is growing, but you have to wait for the durva to leave their body. That was the most stress that the patient and I had. Like, it was even more stressful than knowing that the cancer grew as just waiting, because you had the drug, she had the drug at home, and we were like, we have to wait, right? So I put this patient through this journey, and unfortunately she had disease progression, and osimertinib was the best option, but durvalumab was in her body, right? And there is no way to dialyze durvalumab like we can do it with platinum-based therapy. Yeah. So you have to wait, and that is very stressful.
But what about the PD-L1 negative patients who? That's a big group, and it is I think it's much more ambiguous than EGFR, where almost everybody, well, many of us are quite unenthused about including these patients for immunotherapy.
I do treat the PD-L1 negatives in part because we know the heterogeneous data of PD-L1 and the sample size and bias in these patients. And we know the high, recurrence rate in stage 3A, 3B on resectable, right? We're talking about 60, 75% or recurrence rate. I have a good conversation with the patients with PD-L1 negative disease, and we discuss the options. But I'm most likely to treat these patients because, the recurrence rate is so high, understanding that you have to have a good conversation with the patient. So I guess the short answer is I mostly treat the patients with PD-L1 with consideration Durva. It also depends on the genotype and phenotype of the patient. Some of my patients may have been heavy smokers and they have, some histologic characteristics that show that, yeah, the immunotherapy may be for them, but this sample says that the PD-1 is negative. So like everything in oncology, there is never a straight answer, Jack. We never say, yes, this for everyone. No, it's like, depends on the patient, conversations, and we
You're
go from
always
there.
going to be right with it depends. Yes, I
It
agree.
depends. Like in Dr. House, it can be lupus.
Yes. So Estella, what's your view? I think, the difference to me between PD-L1 and EGFR is we know there's real concrete harms that you can impart, and the data all over immunotherapy and EGFR or several other driver mutations dissuades us. But with the immunotherapy and PD-L1 negative, it's more just it probably doesn't work as well, but it's not necessarily going to harm. So what's your take on this if you have an approval that allows it?
So we treat those patients as a whole who are PD-L1 negative, and I will speak for our radiation oncologists who are still in a way convinced that there is some level of synergy between following radiation with immunotherapy, that you could possibly turn some tumors into hot tumors that may respond. And these trials were not powered really to see the differences by PD-L1 status. So like Nar just mentioned, there may be a patient that the biopsy was PD-L1 negative, but another component of that tumor that we didn't biopsy was PD-L1 positive. And we will be taking away a great potentially curative option for a patient like that. So because we don't know and we don't have a better alternative for those patients, we have treated them.
Thank you. I'd like to turn back to a patient who is on the bubble, potentially a candidate for surgery. But when you look at the films, you're at a multidisciplinary clinic, and the surgeon feels it's potentially going to need a pneumonectomy. How much or how little does that matter? Do you have a mindset that if you're talking about needing a pneumonectomy, and for the public audience, that means having a surgery to remove an entire lung rather than a lobe, 1/3 or half of a lung, depending on which side. So a bigger surgery, and some would argue that it's a disease unto itself to have a full lung removed. It's certainly challenging. Does that lead you to think if you're thinking a pneumonectomy, you should probably not be thinking about surgery? Or does this lead you to maybe think of giving preoperative therapy to shrink it down? Is that a goal for you very often? Riyaz, maybe I can start with you on this one.
Yeah, I think so. This is a really important question, and it's a question that there isn't a lot of trial evidence to guide us. And in my experience, working through several MDTs, different surgeons have different thresholds for surgery. Different radiation oncologists have different thresholds for what is encompassable, what is not. This is a very, very gray area. Right. And decisions that are made are very individualized. And it's not that easy just to just make some sort of blanket statement about how they're managed, because it is very individualized. But as a general rule, if our surgeons feel, I think the patient has the best chance of cure for early lung cancer is surgery, basically. And if the surgeons feel they can offer surgery, they always will. And if they feel that there's a particular bit of anatomy that is pushing the patient to a pneumonectomy, a particular subset of the disease, its location close close to the carina. I mean, they can do resections very close to the carina now with these sleeve resections, sleeve lobectomies, etc., etc. Then I'm not averse to giving some neoadjuvant chemo if they feel they would want me to do that. Even though that, I have to say, that is not a standard of care in the UK. It's highly controversial and causes huge debate. I mean, we can have quite robust arguments at IMDT between us about the management of individual cases like this. They're very complicated.
Right. I think it's a really good point just to underscore. There is no universal definition of unresectable disease. That is certainly a product of where you are, how aggressive your surgeon is, and somewhat the desires of a patient, and whether patients can be converted from not necessarily resectable to maybe moving into that camp. Estella, what's your
Yeah, so we have,
it really varies by location.
It does, and we have very heated discussions in Miami about this. And
which is at least a consensus. Everyone argues about these.
But we participated in Checkmate A16, which is a trial that randomized patients to chemotherapy nivolumab versus chemotherapy alone before surgery. And we enrolled patients predominantly who were stage 3. And from that experience and the activity that we saw in that trial and that has been published in terms of disease-free survival, at least of pathologic response, not disease-free survival, pathologic response, we are favoring some of these kind of gray areas for an induction that includes immunotherapy. And in that trial, they excluded patients who had EGFR and ALK. So it would just be patients that present. And in that study, what they have presented is a small study, like 336 patients or so, but there were less pneumonectomies in the chemo IO arm. But one thing that really confuses me sometimes when I speak with surgeons is that there's a camp of surgery, thoracic oncologists who say that if you needed a pneumonectomy before induction, you still need a pneumonectomy after induction. And there's another camp who's more flexible, that you truly were downstage. And in this trial, they did restage patients in the mediastinum before surgery. So they're willing to do a less aggressive surgery, the patient truly downstage. So I think we don't really know that. I think that trial was very thought-provoking, and there is some activity, and there was some downstaging that was there. I think that was clear, but we don't know still if it applies to every patient.
Well, I think it was a controversial study. I think that trial you mentioned, Checkmate A16, of chemo versus chemo immunotherapy before surgery, 2/3 of those patients had stage 3A disease, and a bunch of the patients in that trial needed a pneumonectomy. I mean, some of my colleagues feel that you shouldn't be probably pursuing surgery if you think there's a solid chance of needing a pneumonectomy. You also brought up the great point that there is this argument or question about should you do the surgery that the patient initially needed, or what the repeat imaging suggests. And one of my former surgery colleagues basically suggested it's like, as a tumor shrinks, is it like a puddle drying up where there may be pockets still of wet out there, and it's not a clean border? Or is it like a balloon shrinking where the new borders are really the issue and you don't need to worry about what's beyond that border? Narjust, what's your both perspective and sense of practice patterns, and in terms of aggressiveness in favor of surgery on the bubble?
Well, I guess I'm going to answer depends again, but I think, having a good conversation with the surgeon has been always important, and having the multidisciplinary clinic, it is always good. I was raised by 2 surgeons, so if you ask the surgeon to take it out and they can take it out, they will take it out, right? So I think it's good to hold in sometimes a little bit. Hey, let's just talk this a little bit better, to make sure the patient has better outcome. I think before even Checkmate A16, I had some special cases in which I would do neoadjuvant therapy, but they're more rare than the section, I think. And this is, understanding that my patient population a lot of my patients are very fit young women, so they're able to take the chemotherapy and then go to surgery, but that's not the case to every patient. So I think multidisciplinary discussions are important. I have done it before, Checkmate A16, but it's not like the standard of practice for me.
Okay.
Although, Jack, I know that you don't like that trial, but you know, 1 out of 4 people, one out of 4 people in that trial had a complete pathologic response.
I don't want to say I do like that trial. Actually,
okay, you do like that.
I do. And I just think actually Dr. Ford, who presented it, kind of brought up that it has been criticized for the pneumonectomy rate. I think the results are very provocative, and we'll turn to that in a moment. I think it's interesting. One aphorism that Narjust comment reminded me of is never ask a barber if you need a haircut. But if I could just get a very brief answer from each of you on the general question, Riyaz, you brought up in my heart of hearts or something like that. I think that if patients can't have surgery, they should. We have older data that looked at patients who would potentially go either way that showed essentially equivalent survival for chemo radiation versus chemo radiation followed by surgery. And that was before adding immunotherapy for the non-surgery patients that really improved survival. I would suggest that we shouldn't think of non-surgical management as a consolation prize necessarily. And I'm just interested, to me, that the results with durvalumab immunotherapy kind of tip the scale that if you need to shoehorn a patient into surgery, you shouldn't necessarily force that issue because the non-surgical approach has improved and is not a bad option. And I just want to get your sense of whether that's valid, or any other folks about whether surgery is by all means what you should do if some surgeon says they will.
So my view on this, I entirely agree. I think non-surgical treatment of early lung cancer has come on so much that you can start questioning what is the role of surgery effectively. The reality is, in my practice, in my clinical experience of meeting patients, this isn't generally a question that comes up because patients generally fall into different groups quite easily. Most people that get diagnosed with early lung cancer who are fit, who have no comorbidities, in good physical state. There are some who will decline surgery. I've met people who are just terrified of the thought of undergoing surgery for actually very resectable disease, but vast majority do go and have surgery. And the majority of patients that, often patients with high comorbidity indexes who wouldn't be very good for surgery, don't often come to our clinics touting for surgery. They often are very hesitant about surgery because they know that there's a chance they may not make it through. So I think actually generally it's not in clinical practice. Patients just fall into these groups naturally. It's quite clinically obvious what the right thing to do is for that patient. And the number of patients where this is a real, genuine discussion is actually fairly small. And I just don't think we have that level of data to, there's no simple answer to this. You just have to put all your cards on the table with the patient, with all the relatives. Sometimes we have patients go and have a radiation oncology appointment, go and have a surgery appointment, wait a week or two, think it through, see them again, and they'll make a decision.
I think you also raise a great point that we haven't articulated here, which is stage 3 is a very heterogeneous group for lots of reasons. The extent of disease, the characteristics of the disease, the features of the patient, their comorbidities, which is other medical issues, their place socially. I mean, all of these issues are very important factors that speak to the heterogeneity. So it really doesn't make for quick rules. Estella, can I get your thoughts on?
I mean, I agree with everyone that this is why we have multidisciplinary conferences really to discuss stage 3 disease, and patients do have their preferences, and we need to kind of start there what the patient's preference is. But I will say that for stage 3 disease, we do draw the line. Like if you have bulky disease, multi-station disease, our data suggests that you're going to recur most likely systemically. So that's why we kind of favor an approach that has immunotherapy consolidation if the patient is a candidate, because the systemic recurrence is really what we're trying to prevent.
Narjust, any different perspective here?
No, really. I think, it is, because what it can be a good option for one patient can be a horrible option by another.
So it depends. Yeah.
It depends. But I think everyone involving, I think, not only the surgeons, the radiation oncologists, we have something called pre-rehabilitation that some of these patients that are a little bit older can be on before surgery. So they pre-rehabilitate as you do all the other work. That has really, allowed for these patients to tolerate surgeries that can be significant. And we need to, remember that pneumonectomies are high mortality, high morbidity, and these patients are never the same after a pneumonectomy. Like that nerve pain can stay there for a year or two. So
right. Let's turn to the question of preoperative versus postoperative therapy. We have trials that are positive, at least for significant improvements in disease-free survival, and FDA approvals for immunotherapy and EGFR inhibitor therapy with Tagrisso post-operatively. Estella, you mentioned previously that your center participated in this important and I really think provocative trial. Checkmate A16 gave 3 cycles of chemotherapy with or without Opdivo immunotherapy. And the results showed a marked improvement in tumor shrinkage. And when they looked under the microscope, 10 times as many patients had no evidence of disease viable under the microscope after the treatment, compared to, it was only 2% or 2% and change versus over 20% between chemo with or without the Opdivo. But we don't have an FDA approval for this. And in some ways, these are conflicting, competing platforms, ideas. So where do you see preoperative versus postoperative fitting in? And how competitive are they, would you say?
So, these trials, preoperative and postoperative, they're very selective. So in the Checkmate A16, we were only able to enroll 2 patients because you had to have all this restaging. You had to be a patient that could have waited that time for the whole workup to proceed with surgery. In the trial, they did have most patients had surgery within 6 weeks of finishing those 3 cycles of chemo or chemo IO, but there were some delays. And I know that's one of the concerns. Like if you do preoperative therapy for a patient that you could possibly take them straight to surgery, who are you delaying? So I don't think, and I think you can tell in the trial, a lot of investigators didn't feel enthused to enroll patients with stage 1B, which was included more than 4 centimeters, or stage 2. That really this is something that we clinically would favor for someone who's more high risk. But I think that 1 out of 4 patients having a pathologic complete response rate must translate into something. Are you going to get that benefit if you add immunotherapy post-op? We don't really know because we don't have survival data for any of these trials. Right. And that's what we need to be able to tell us, it's better to start early, you'll do better surgeries, or you get better outcomes. And we don't know that yet. I will say that patients tolerated that very well. There were actually more patients that finished the chemo component of this trial than the chemo IO. So correction, there were more patients that finished chemo IO than chemo alone. So I don't know why that happened, because you would think if you have IO, you had more side effects, but it was well tolerated. That was our experience. It was well tolerated. Although I'm sure if you do a very larger study, you will find patients that have horrible complications from immunotherapy and they never got to surgery. So the trials is only, it was a trial of 300 and so people. So we don't know,
right?
You don't know enough.
There weren't a lot of those patients who stumbled on the way. I mean, that's always a concern, is you can lose patients from complications or progression before they get to surgery. But there's also the real risk of patients who go straight to surgery and are either unable or totally uninterested in anything after the surgery. And so there's really a question of, if your goal is to give the total package of whole body therapy and local therapy like surgery, are you more likely to get through by starting with the systemic and then, having more people motivated for surgery than losing people after going through surgery and saying, I'm not doing a thing after this? Narjust, what's your take on the role of preoperative therapy now and maybe in the future, in a world where we already have a toehold and some important approvals for postoperative?
Well, I think for neoadjuvant therapy, still the story is incomplete, right? And is not approved yet.
Right.
The endpoint of complete pathological response is a evolving endpoint for lung cancer. It has been established in other diseases, but it's still an evolving endpoint, right? This is the first study that we have such a big difference of 25 to versus 2%.
Yeah.
So the endpoint is new. We have disease-free survival and we all get very excited, but it's like the previews of the movie. You still don't know if the movie is good. The previews get you all excited, and that's what disease-free survival can be there. And we need to be very conscious, because we have been in studies in which disease-free survival has been great, and then poops, overall survival is not significant, and we're putting our patients through a lot. The benefits of neoadjuvant therapy is what you said, is that the patients are able to get therapy ahead of time, and if something happened with surgery, you have better compliance with that.
And you get
a year of atezo is a lot.
Oh, absolutely. I think that's a real thing. And one of the things that I didn't articulate, and Estella, I really think we should highlight that, to see that big a difference over just 3 treatments, just 2 months of therapy, compared to extending the time that patients are coming into the oncology clinic for a year or something, or even 3 years of pill-based therapy. These are legitimate questions of, a lot of people would like to move on with their lives. If you can achieve the magnitude of benefit preoperatively with a few months, I think that's something. Riyaz, what are your thoughts here on, pre-op versus post-op? I think you have also partly seen the evolution. I was certainly part of in the world of lung cancer when neoadjuvant chemo was kind of coming up on the side, and it got killed by all the positive adjuvant trials. I wonder if we're going to see that.
So I think one of the problems we have in lung cancer is we're evolving multiple standards of care very quickly. And so in the same year that Checkmate A16 has come out, which is neoadjuvant chemoimmunotherapy, Empower 010 has come out talking about adjuvant chemo. And so the adjuvant chemo's, obviously, it's a positive study. You have an FDA license, you're using it in your clinic. But obviously those neoadjuvant trials that are currently running, and 816 is just one of several big randomized phase 3s, don't have in the control arm what would be considered optimal adjuvant therapy today based on the data that's just come out in the last year. So it's very, very difficult for us in a field where the standards of care are changing so quickly to actually be able to answer the key question a patient wants to know who's diagnosed with lung cancer in the next 6 months that's operable is, should I have neoadjuvant chemo first and then my surgery and then adjuvant immunotherapy? I mean, who knows? The other issue I do know, there have been lots in multiple tumor sites, pancreatic, gastric, of perioperative chemo trials, of chemotherapy or systemic treatment where the trial protocol has mandated that treatment before and after surgery. And you always see, it doesn't matter what cancer it is, the number of patients that manage to get postoperative treatment is a fraction of the patients that went in. After surgery, a good number of patients are completely, not in a physical state. They've had complications, they're fatigued, they've lost weight, they're frail, they're not in a position to complete the protocol. So, drop off is a huge issue for us in oncology, where, You may have a subsequent line treatment, but the previous line treatment has toxicity. So only a fraction of people ever get through to subsequent lines of therapy. So, I mean, there's no real answer to the question, but it's a very difficult thing because we are about to enter a phase because of having multiple standards of care and not really knowing. We're going to have to do prospective trials to answer this.
Yeah, it's a problem because these trials, especially with overall survival, takes a long time to mature. Yeah. So,
and there's no real incentive for pharma to do them. If they have once you have an FDA label, you've done your job. I mean, yeah. It's academia that has to answer these key questions.
Right.
If there's interest from the community.
We have about 10 minutes left, so I want to get through a couple of topics quickly. One is we still struggle now with which patients preoperatively, especially postoperatively, in a world where we have treatment choices for postoperative therapy, which patients really need it and which patients are cured already from the surgery. We don't want to overtreat those people. And, you know, certainly some patients with stage 1 disease and a subset of patients with higher stage disease are as cured as they can ever be. And we don't want to extend years of therapy and potential side effects and cost. We have new technology, circulating tumor DNA, that sometimes detects what we call minimal residual disease. You can find some small amount of tumor DNA in the bloodstream. It is not a standard test right now. It's just looking provocative. So I would ask you all where you see this now. I mean, are you using it? It's starting to be kind of marketed ahead of a lot of data. Where do you see it now? Where do you see it in the future? Is this likely to be a tool that in 3, 5 or so years is as widespread as PET scans in our management? Riyaz, can I start with you here?
Yeah, it's very timely because there's been certainly a very interesting publication recently that was that I've seen on Twitter on this very issue. Unfortunately, Twitter's where I get a lot of my up-to-date medical information from. Look, I think that where are we going to be in the future? I've no doubt that ctDNA technology, so liquid biopsies, are going to provide a lot of information in this space. They hopefully will be able to predict for us the patients who are going to relapse. And then we need prospective trials because we do need to check this prospectively to check whether early intervention with chemotherapy, immunotherapy, whatever it is actually going to change the biology of the disease in those patients. We need to see if adjuvant chemotherapy works in people who are molecularly negative. I mean, I've no doubt it'll have a role, but there's a lot of questions that need answering in prospective, well-designed studies.
Narjust, your thoughts here?
So I'm a little bit more on the conservative side because we don't have good data about it, and I'm afraid that patients are going to be called failure. They're going to say that they failed treatment or they had disease progression and they're going to be starting on therapy too soon. We don't have tumor markers in lung cancer like other diseases like pancreatic cancer, breast, or colorectal cancer. And we have learned from those diseases that sometimes back in the day, we used to follow these tumor markers and patients were going to be starting chemo based on a number. So I'm very conservative about circulating tumor DNA in early stage as calling a disease progression when there's nothing in the scans. I think, yes, there is going to be a role for ctDNA, but it's very, very early. And I would hate for my patients to go on therapy too soon without having a benefit of survival, because these therapies are not only expensive, but they affect the patient's quality of life. And Jack, to what you were saying between a period of it, like early treatment versus prolonged treatment, we are oncologists. Our patients like those, but the less we are in their life, the better they're doing. Like I had called my patients like, "Hi, it's Dr. Duma," and she's like, "Damn, I prefer to get a call from my dermatologist." And I get it. Like we are cancer doctors, right? So the less time they get with us, the better they're doing.
Estella, your thoughts here on current versus future ctDNA use?
I mean, I think that we need a better way to monitor patients with minimal residual disease, and ctDNA seems to have an answer, but it hasn't been tested prospectively. One of the trials we participate in, the Mermaid trial, does have a prospective evaluation of starting treatment based on a ctDNA test. But I will tell you, these tests, at least in the United States, there's no control. Like I had a patient who came and told me, why didn't you order a Signatera? Why didn't you order a DetermaRx? Like, you're not doing your job. And I'm like, where is the data for all these tests? So I guess, that's another thing, is that you can have all this technology, but until we have the right trial, we could be doing a disservice to patients.
Now, thank you. And my last question is going to be about, we opened with a discussion of molecular testing and potentially broad testing. I think that whether we ask for it or for whatever reason, it's maybe happening now or is soon to happen more. And so the question is, what if you get a result back that shows an ALK rearrangement, ROS1, or one of the other targets, RET, where we've got really good data in stage 4, but we don't have data yet for early stage and resected patients. Are you inclined in any way to extrapolate what we've learned from EGFR with the thought that we may never have good data on this? Or are you inclined to say, look, we don't have good data on this, and this is expensive and potentially has side effects, and so we should really stick to where the data are? I'll go in reverse order of last time and start with you, Estella.
So there are very good trials ongoing to answer the question. Adara is going to open, and there's a trial with ALK. So, but we don't have those trials, and some of our patients don't have the luxury to wait. So what I tell patients is that, chemotherapy can work in your mutation. We're thinking of an adjuvant approach, and we're going to monitor you very closely. That's what I tell patients. I have patients that out of clinical trial, we have requested compassionate use of drug, and I explained to them, we have not finished the Alchemist trial. We have not really learned about how long will you have to take this targeted therapy in the adjuvant or neoadjuvant setting.
Excellent. Narjust, thoughts here?
I think it's to be determined. I'm more afraid of patients being harmed for unnecessary treatment, because then we're, treating these patients like a stage that they don't have.
Right.
And these drugs are $10,000-$12,000 a month. So are you really benefit? Like this swelling in your legs? Is this worth for unknown data? I don't think, I would take a pill for something that is just hypothesizing and a whiteboard when it's bringing financial, physical, and emotional harm to our patients.
Riyaz, what are your thoughts here? Different culture, I think, maybe different mindset about extrapolating, but you tell me, what are your...
Oh no, definitely agree with what's been said. I mean, I would go out of my way to reassure a patient with early stage disease that they didn't need to start going on to stage 4 management pathways. I think that's really, really important. But I do think there are nuances. So for example, EGFR ALK, you would obviously steer away from any immunotherapy is generally what I would suggest. And I think the way you screen patients afterwards, if you've got a patient who's got stage 3 disease, they've got a high risk of relapse, you find they've got an ALK fusion, you might slightly change how you monitor those patients. You might scan them more frequently in the surveillance part of once they've completed their definitive treatment. You may image the brain more frequently. There are little nuances. So it's good information to have because it gives you, knowledge is power, I say. And the more you know about a patient's cancer, the more you can tailor treatment for that person. But yeah, I don't think it's appropriate to be giving stage 4 treatment in early stage disease without data.
I want to thank all of you for really great, thoughtful responses on obviously nuanced questions that don't have clear answers. So I appreciate that these were deliberately difficult ones, and but at least there's no right or wrong answer. The answer is always it depends. So we're going to take a brief break for our current panelists. If you are inclined to stay around for an hour from now, we'll have a Q&A session. Great. Otherwise, we will work with the folks we have. And thank you to our audience. We'll take just a brief break for a few minutes before reconvening for the second panel. Thank you.
Hi, everyone, again. And thank you again, as Jack mentioned, to Narjust, Riyaz, and Estella for the kind of robust discussion. And so for the second panel, we're asking similar questions and also some newer questions in the space of advanced lung cancer. And we're joined by 3 new panelists. And so we have here Dr. Marmorelis, Dr. Satcher, and Dr. Hedge. And similar to what Jack just did, I'll have each of them introduce themselves. And before you introduce yourselves, I wanted to make sure it's okay. In this setting, we've been referring to everyone by their first names. Is that fine with all of you? Perfect. And so Melina, let's start with you in terms of introducing yourself.
Great. Hi, everyone. Thanks for having me today. I'm Melina Marmorelis. I'm a medical thoracic oncologist at the University of Pennsylvania with a specific focus in lung cancer and mesothelioma.
And let's, Adrian.
Thanks, Ivy. I'm Adrian Satcher. I'm a thoracic oncologist and affiliate scientist at the Princess Margaret Cancer Centre in Toronto, Canada.
Perfect. And then we'll round it out with Aparna.
Thank you. I'm Aparna Hegde. I'm a thoracic oncologist at UAB, and my interest is in drug development.
Perfect. So over the next 55 minutes or so, we'll think through some, I think, exciting questions that really get to the core of how we think about newly diagnosed metastatic or advanced non-small cell lung cancer and some of the nuances in practice. As you heard from the previous kind of panel discussion, management of early stage lung cancer is very nuanced and is borrowing on a lot of the principles that we use in advanced lung cancer. And so let's start first. So kind of a common scenario that we all encounter in clinical practice. You have a newly diagnosed patient who has a new diagnosis of metastatic non-small cell lung cancer. And we know now kind of from multiple kind of practice changing publications and kind of with the shift in the therapeutic paradigm that biomarkers are very critical, right? We always strive to get it right in our first line therapy. And because our audience kind of encompasses kind of different expertise, I wanted to first make sure we're all on the same page by discussing what are the key biomarkers for newly diagnosed metastatic non-small cell lung cancer. What do you consider the must test? And we'll have anyone, perhaps so everyone doesn't talk at once. How about Adrian? Let's have you start off.
Absolutely. So I think in the metastatic setting, we're really in a reality where you have to have NGS on everyone, and then also PD-L1. There are kind of a list of potentially targetable genomic drivers is expanding rapidly. I think most recently with kind of KRAS G12C entering, and I think too beyond just our standard of care options, we increasingly have clinical trial options in the metastatic setting that are looking for very specific genomic targets. And so having broad NGS not only ensures we can kind of give people all standard options, but that we can identify trials for them as well.
Yeah, and then oh, sorry, there's an echo.
Oh,
sorry. And when you say broad NGS testing, and this is, I just want to clarify, this is to distinguish from doing single gene assays like FISH for ALK or kind of even looking at PCR tests for EGFR. And in a practical sense, can we kind of, I know that that's still employed by centers and there is some diversity in practice, to kind of talk about why that type of strategy may not serve us as well as comprehensively looking for all of these things at once. And maybe we can have Melina start and then Aparna add anything additional you might have.
Sure. So I think the first thing I'll say is that the NCCN has a list of biomarkers that they recommend that are tested prior to starting first-line therapy, and that continues to expand, with every iteration of the guidelines. So including EGFR, ALK, ROS1, RET, BRAF, MET, and it keeps growing. And so, it may have been feasible in the past to do single gene testing for a few of these. But really, it's been shown now that it's both more time efficient and cost effective to actually do a larger next generation sequencing panel right at the outset, so that you're not wasting the patient's time, you're not wasting hospital resources or precious tissue, from a biopsy. So I think that's certainly the preferred approach. There's also guidelines to incorporate concurrent liquid biopsy testing, so meaning from peripheral blood, to also kind of get to the answer faster. So this is an evolving space, but I think the guidelines are clear that it really needs to be a broad panel.
Yeah, so I agree with whatever has been said so far. So our practice over here is also to get a comprehensive panel upfront, regardless of histology, because for adenocarcinoma, I think it's absolutely necessary to pick the first line of therapy. But in squamous cell carcinoma, having this comprehensive panel helps us plan for clinical trials down the road. So we are not kind of scrambling when the patient has disease progression. And also now there is a KRAS G12C inhibitor that's FDA approved in the second subsequent line setting. So it would be good to have that information upfront, so we get a comprehensive panel here. And with sequential testing, we end up losing tissue, wasting tissue, and it also takes longer. So that I agree, there is data now regarding potential cost savings, as well as shorter or at least equal turnaround time with a comprehensive panel. So that's our practice. And we over here also do ctDNA and tissue NGS at the same time. So this also helps us save time. Sometimes, we find out after 2 weeks that the tissue isn't enough. So, kind of do both at the same time instead of waiting.
So a lot to unpack there. So I think that one of the advantages of having a virtual forum and having forums like this is that we get oncologists who are practicing in multiple locations. And so I get to kind of get an appreciation of whether there's variation in practice. And so Aparna just said that internally they do, at least at our institution, they would do concurrent liquid and tissue testing. And can you clarify, do you have an in-house tissue testing platform, or do you send out?
We send it out.
Okay.
Yeah.
And then is there any difference? Do you kind of, Adrian and Melina, also do both at the same time? And do you use a send out or an internal panel?
So we have an internal tissue panel, so from a biopsy, and then we send out for liquid biopsy for peripheral blood. That we have an initiative to move that to kind of the very first visit, or even soon, or even before that. So it is kind of part of our pathways and guidelines to incorporate that right up front.
For us, we do our kind of a broad NGS and RNA-seq panel internally, but part of that is just because we're also kind of the hub for all of our local cancer centers for testing as well. So we do it in-house, and then we bring in even more. And then same for ctDNA. We like to do both in tandem as well. And I might actually add on there, like, what are all the centers here doing in terms of reflex testing? So for us, the pathologists order the NGS panel way before we even see the patient. Is that kind of standard for everyone else as well?
We have specific guidelines about reflex testing, and a sample has to meet those in order to be reflexed. And it, some of the parameters are that it's non-squamous. It has to either be a certain size or be a lymph node or a metastatic biopsy. So there is a kind of a workflow, but the majority, when we look at it, do get reflexed now. That should.
So for us, we have a weekly tumor board meeting where we discuss all of our new patients who are coming to see us the following week. And we kind of, look at the stage and the histology, and we initiate the genomic testing as well as PDL1. Because in earlier stages, we use our in-house panel because I don't think we need a huge comprehensive panel in earlier stages, because the FDA approvals are only for limited things, just EGFR and maybe PDL1 because of the recent Atezo approval. So we look at the stage. The pathologist probably doesn't know the stage when they have the biopsy. So we wait for the weekly meeting to decide who to send out the tests on.
Okay. And then one other point that Aparna you had made is that you test uniformly across histologies. Is that practice the same for you, Melina and Adrian? Are you testing squamous and non-squamous equally?
We're testing both. I would say it's probably not equal, as the reflex tests don't get sent on squamous currently. So that may start to change, but it hasn't changed yet.
And if you're not kind of reflexively testing, are there particular patient characteristics that might sway you to do the testing in squamous?
Yeah, definitely. I mean, I think the first thing is if there's any hint of adenocarcinoma in the specimen, certainly would push us towards initiating testing sooner. Certainly if the patient has either a light smoking history or no smoking history, that would certainly push us to look for other driver mutations. But in general, I think most of us think that we should be testing all squamous cells. It just doesn't, it's not quite incorporated into our reflex pathway yet.
Yeah, same with us. We won't reflex test a squame, but if it's a young patient, never a light smoker, or anything else that seems a bit strange, we'll definitely test. And then more broadly for squames in general, we have a tendency to run the NGS anyway, but just do it as a research panel. And again, feeds back into the potential for trials and other options. And the odd time you find a UV damage signature or something like that that suggests an alternative primary. So
fair enough. And Adrian, you led some of the initial work in this area, but one kind of term we've glossed over so far by talking about concurrent tissue and liquid biopsy is really kind of the advance of liquid biopsy and how it's now increasingly incorporated into our practice. And again, recognizing kind of the broad expertise of our audience, can you tell us what is a liquid biopsy and what is the potential advantage of that over a tissue biopsy?
Yeah, absolutely. So back in the day when I was also in Boston, had the opportunity to kind of lead some of these early studies. And the idea of liquid biopsy is really using cell-free DNA, so free-floating DNA in the blood, to essentially do all the genetic testing that we would otherwise do on a biopsy or a tissue sample from a patient. The advantages really are that it is non-invasive, it is potentially faster, and sometimes can tell us things about a tumor that we might not be able to tell from a biopsy, especially in cases where you're looking at something like a mechanism of resistance to a treatment that might be present kind of heterogeneously in a patient's cancer, meaning not at all metastatic sites. So I think we've kind of evolved into a state where there are things we can learn from both tissue and liquid biopsy. And hence the importance of kind of, I think, looking at both in tandem. Thinking forward, where I see liquid biopsy really going is as increasingly a technique to monitor likelihood of recurrence after curative treatment, and potentially response to treatment generally, including in the metastatic setting. I think there's still a lot of work to be done to define how to best use it in that setting, but I think there's great utility to it for that purpose.
Man, so you mentioned, oh, sorry, if you could, you mentioned the future, but I guess a question for the now. You guys, so we're talking so far about using liquid and tissue concurrently, and I know that perhaps there are some providers where you use one or the other, right? There's some instances where you don't get results from both. And in light of that, is liquid sufficient? Do we think that we get all the answers for liquids, or are there instances where you might be worried that liquid might not give you the full answer in terms of actionable alterations? And maybe we can have Aparna start with this one, and then Melina, if anything additional.
Yeah, so with the ctDNA, kind of, if it doesn't show any actionable alterations, we prefer rebiopsy because we may miss like ALK fusions or MET exon 14 skipping mutations. We tend to miss those on ctDNA. So our preference is to rebiopsy in that instance. Also, these two are kind of complementary, the tissue and liquid biopsy. Sometimes you find things in tissue that you don't pick up on the liquid biopsy and vice versa. So, if the patient only got liquid biopsy and the tissue was insufficient or poor quality or whatever it was, and the liquid biopsy doesn't show anything actionable, then we do prefer getting a rebiopsy.
Yeah, I think the only thing I'd add is the kind of the way that I think about it is, these tests often show the same things, right? Liquid biopsy and tissue biopsies very often show the same things, but they can show different things. And if that difference is something that's actionable, then that's really important difference. So I kind of think of it as additional shots on goal, having both of these modalities to be able to find, what you're looking for.
No, and I think that that's reasonable. And I think that one thing that we should clarify is that in current practice, the liquid biopsies that we use are not going to tell us PD-L1 status. And we've mentioned that PD-L1 is a relevant biomarker here for selecting therapy. And so to pivot a little bit, everyone said kind of uniformly, enthusiastically, and I completely agree that NGS is the standard, right? We should be doing broad molecular testing on all of our patients. And so recognizing that, I was a little humbled and kind of disappointed at a couple of recent presentations at ASCO this year that suggested that the uptake of NGS and kind of broad molecular testing is not what we anticipated or what we hope it will be. And kind of for background, these were presentations given looking at community level data, first looking at kind of the Flatiron database, demonstrating that, number one, as you mentioned, Adrian, at the beginning, NGS helps you, and Aparna helps you select patients for trials, right? And they showed that, but also showed that fewer than 50% of people were getting NGS. And there were also kind of racial differences in terms of who was getting, and kind of racial and geographic differences have been shown about who's getting NGS testing. And then the second study was really looking within the US oncology network and showed over time, yes, the trend in testing for key biomarkers had increased, but it still was woefully low. And so we are all speaking from largely an academic standpoint, but I think we get a lot of referrals from the community setting as well. And so I wanted to pick all of your brains about what do you think are the leading barriers to seeing the increased uptake of NGS in the community setting? And how can we improve that? And anyone can jump in, and then others can kind of chime in around it as well.
I think oh, sorry, Aparna, go ahead.
No, go ahead, it's okay.
I was going to say that, I think actually immunotherapy has really hurt this. And what I mean by that is that PD-L1 is an easy biomarker to get. It's now kind of reflex on a lot of tissue for non-small cell lung cancer. And we have certain parameters for when we would consider immunotherapy alone versus chemoimmunotherapy. And that is very easy for people that treat a lot of other cancers to make a decision on. And it's been heavily marketed and advertised and presented at conferences. Biomarker testing for molecular data is way more complex. Not only are you looking for alterations in different genes, you have to know which alterations you're looking for, and then you have to know which targeted therapy you're going to use. It's a far more complex decision process, and not that people don't want to do that. It's just that it's a very hard thing to keep up with and wrap your head around.
So what I'd like to add is, one of the barriers is probably inadequate tissue, right? So you probably kind of say, okay, PD-L1 is high, the tissue is not enough, I'm just going to use immunotherapy. That may be one of the issues, which can kind of be, if you get ctDNA, you can kind of, overcome that to some extent. The other one is probably insurance. We here at an academic center, we have not really faced much of this, but hear from colleagues in the community all the time that, insurance denies what is, standard of care. So I think this is something that has to be addressed at a legislative level, I think. That is a significant barrier. And another thing is where, the idea that these genomic alterations only occur in certain ethnicities, that's probably one of the ideas that stuck. We read that the EGFR's aberrations are more common in Asian ethnicities. So it's kind of probably, it sticks in people's heads, and it probably influences the decision to do genomic testing. So another thing I would like to add is the genomic reports that you get, the NGS reports, are so complex. They're so difficult to interpret. There are all these VUSs, all kinds of things, which is kind of intimidating. And one way is to kind of have a molecular tumor board that can be attended by the community that we serve, community oncologists, and also us within an academic institution, so that our genomic teams can help people understand what these mutations mean, and also help figure out if the patient is eligible for a clinical trial. So there are multiple barriers, and there are ways to overcome them if we try.
And I kind of echo the thoughts and sentiments of everyone else. The one thing I would add on to this, though, is I think this is a problem that has been going on for a while, and it is not getting better at the rate that we had hoped. And it is now at the point where I think it's something that it is really like harming patients. Like people are missing out on the potential for treatment. And I think if we found that there were centers where breast cancer patients weren't getting HER2 testing or something like that, there'd be an like inquisition into what was going on. Yet many centers are not able to access proper biomarker testing for lung cancer patients. So I think we're at the point where we need to investigate this further as a field to understand the barriers in a really granular way and address them centrally. And I think that maybe needs kind of action both as a field and then from like a regulatory and legislative point of view. I think in at least north of the border, what we've been trying to do is make sure that testing is a key quality parameter and that it is centralized to a certain degree, so that it is very hard for any center to kind of claim ignorance about the importance of testing. But again, I think this is a complex problem too, so I think we really need to understand what is going on at each individual center, because I think we might not have line of sight onto all of the problems from our vantage point at academic centers. On a final point on that, like I think the socioeconomic and racial overlays of this are particularly disturbing, and something that needs to be kind of looked at very carefully and expeditiously.
No, and I think that you all raise very good points, right? I think that we still probably haven't fully appreciated the scope of the problem, and I think to understand the scope of the problem is the first step to really kind of implementing things. And I agree that it's not practical. It's helpful, at least at a single institution level, to implement these changes, but we need to think more broadly. And I think that potential things that I've heard are liquid biopsies being kind of a great equalizer. It's something that people can do even if they don't have an internal assay. Also, kind of deconvoluting these complex reports that we get that are mainly written for the molecular pathologist, making it more kind of user-friendly. And I think I've heard this across kind of multiple forums as kind of a key thing that needs to be implemented. The part I really like the idea of molecular tumor boards, and I think that kind of demystifies some of these reports. And I think another thing that we ought to think about too is that, and we're seeing through things like GRACE, right, empowering patients, right, and put it in the hands of the patients who have a new diagnosis to know that kind of biomarker testing is important, and then that hopefully then it can flow kind of and bi-directional, basically, not just one person governing whether or not someone gets molecular testing. I think these are all key points. And so in turning a little bit towards a different question, and so we've mentioned biomarkers, and Melina, you mentioned how that NCCN list of ever-increasing list of relevant biomarkers. And for the most part, our biomarkers have really pertained to first-line treatment to date, right? There have been studies that show this therapy has an overwhelming benefit, response rates in the 70 to 80%. And to us, it's been a no-brainer to select these therapies as first-line treatment. But this year was unique in that we saw approvals of targeted therapies to some extent for targets where the response rates were great because there was nothing else in that area, but we're not completely sure if they're better than chemo. And so these are second-line approvals. One particular target I wanted to talk about was KRAS. And so we have our first KRAS inhibitor approval. And my question perhaps we can have Adrian start with kind of discussing your understanding of where we stand with KRAS targeted therapies. And then from there, we can go into kind of how do we use them? Do you think it's ready to be used in the first line setting? Do we need more data? Do you preferentially use them in the second line? And we'll have Aparna and Melina weigh in on those.
Yeah, so we have seen kind of a fantastic explosion of KRAS G12C inhibitors over the past kind of couple of years. And that is kind of on the heels of years and years of failure to target KRAS, despite best efforts. I think what's important to keep in mind with the G12C inhibitors is that the biology of KRAS is complex, and these inhibitors are not TKIs. They're a whole new class of drugs. So the response rates are more modest than what we've seen with an EGFR TKI or an ALK TKI. But as you say, they're not bad compared to later line options. Now, that being said, the field is moving so fast that we are now already looking at combination therapy that I think has great potential to take what is maybe a modest benefit for monotherapy and turn that into a really great benefit with the right combination. And so in that context, I would say it might be worthwhile to wait a little bit before we decide on testing some of these agents in the front line. Except with certain subgroups. I think there are some subgroups of G12C that probably do really poorly with standard initial treatment with something like chemoimmunotherapy. And I'm thinking specifically about the KRAS STK11 co-mutated patients. There might be maybe a niche there for G12C inhibitor monotherapy in the front line. But again, the whole field is moving so fast that I worry that if we start running a bunch of frontline studies of G12C inhibitor monotherapy, we may just end up having a better combo option and then not really making much use of whatever comes out of those studies. At least those are my initial thoughts.
And Melina, anything to add to that? And maybe one particular question for you, if you have a newly diagnosed patient with KRAS, so newly diagnosed or have already had chemotherapy, let's make it a little easier, or chemoimmunotherapy with KRAS G12C. Are you reaching for the approved agent, or are you going for clinical trials of combinations right now?
Yeah, it's a great question. So I think the first thing I'll add to what Adrian said is, I agree that there's a niche potentially for kind of first line, but I think also there's a huge group of patients with KRAS G12C that do really well on first line chemoimmunotherapy, and that might be, the best first treatment for them. In terms of, what to do with the patient that comes after they've had first line treatment and has a KRAS G12C alteration, certainly we're always looking at clinical trials, and we have, a few open in this space. And so we would certainly prefer patients to look at some of those promising combinations. But in the standard of care setting, certainly we'd be reaching for sotorasib in the second line setting.
I agree with what's been said so far. In the first line setting, yeah, I agree. There have been now quite a few retrospective studies that have looked at how patients with KRAS mutations do with immune checkpoint inhibitors. And especially with KRAS G12C, some patients respond really, really well. I personally, I've seen my own patients, some of my patients respond very nicely to frontline immunotherapy. So so I would go with the standard of care right now in the frontline setting. In the second line setting, of course there is an FDA approved drug. We would go with that or with a clinical trial of a next generation KRAS G12C inhibitor or a combination trial that's available.
Yeah, and I think that this is KRAS G12C is one of, so EGFR started it to some degree, but it kind of gets at the point of the imaging, the molecular testing reports really mattering, right? G12C is not the only KRAS mutation that can be seen, right? It is the most common in lung cancer, not necessarily in other kind of conditions and other diseases. It amounts, in our understanding, to about 10 to 15% of kind of non-small cell lung cancers. But there are other KRAS G12 mutations, G13 mutations. And so it's really important to highlight that these inhibitors are specific to G12C mutations, and so it should not really be given for people who have other alterations. And so again, we need to simplify our molecular testing report so it's evident to the person treating the patient and to the patient themselves that this is what you have. And so kind of to pivot away from our molecular targets for the moment, and talk about our approach to patients who may not, treatment of patients who may have cancers who don't have actionable molecular alterations. And here we've highlighted that perhaps the most relevant biomarker in this setting is the PD-L1 status. And so for Aparna, if you have a patient with a newly diagnosed PD-L1 high non-small cell lung cancer, how do you think about treatment? What do you tend to reach for? And does it kind of differ by histology? Are there other factors you take into account to decide on your regimen?
Yeah, so, the standard of care, it's kind of, you could use chemoimmunotherapy or you could use immunotherapy by itself, regardless of histology. There are regimens for, to do both. But for PD-L1 high, what I look at is the histology. Now there is, there's some data, it's retrospective, but there's some data that, shows that, squamous cell histology, in squamous cell histology, PD-L1 may not be a predictive marker. Again, it's a retrospective study, but it kind of adds to what I've been seeing in practice. So that is one thing I take into consideration. Also the tumor burden and patient's performance status. These are three things I consider to figure out if we could use chemoimmunotherapy or get away with monotherapy. So that's what I do.
And would you say would you say the majority of your patients with PD-L1 high tumors are getting a kind of monotherapy with a checkpoint inhibitor, or are you kind of mostly giving the combinations of chemo plus
immunotherapy? So we actually have a clinical trial going on over here. So that's our preference. It's anti-PD-1 or a combination with other checkpoint inhibitors. So that's our preference if the patient's eligible for the trial. But otherwise, if they're not eligible for the trial, it depends. If it's adenocarcinoma and they're, PD-L1 is high, then I tend to go with the single agent therapy. But if it's squamous, if the tumor mutation burden is high, I usually prefer a combination.
And then, so Melina, is your practice the same? And then we've talked about co-mutations in the context of KRAS, but do you use other mutations in the molecular profile to influence your practice or inform your practice in any way in terms of the treatment of this patient population?
Yeah, I think, the one thing that I'll add is that I do look at the level of PD-L1. So, when we say high, we're saying greater than 50%, but this is a human that's looking at a slide and estimating a percentage. So, if someone has 50%, that person could easily be actually 48%, in which case you'd be making a totally different decision. So, I do look at the level really in a little bit more of a binary way, not so much in a continuous way. So 90% or greater, and I'm very comfortable with immunotherapy alone in the absence of an actionable molecular alteration. Even in the 70s and 80s, I'm feeling, more warm and fuzzy about immunotherapy alone. Getting down into the lower, 50s, 60s, I'm certainly considering adding chemotherapy. And then, I don't look at histology right now. I think, Aparna, that's really interesting data that you talked about. I haven't been using that in my decision making. but I look more at patient characteristics. So, has the patient been losing weight? Do they have a high tumor burden? Is there a lot of liver disease? Because immunotherapy may not be as effective in, disease that's in the liver. So those are the types of things I'm taking into account in addition to the actual number that is PD-L1.
Yeah, and I echo all these comments. Especially the liver met comment. I mean, I really worry about a patient that comes in with liver metastases getting PD-1 monotherapy, irrespective of PD-L1 status. I think too, sometimes if I have a patient that comes in with like their NLR high, like really high, otherwise unexplained ANC and monocyte counts, that also worries me that maybe they're going to be a bit more refractory to PD-1 monotherapy, and I might lean towards chemoimmunotherapy. Yeah, occasionally you just have those hints that it's a more stubborn tumor from an immunologic perspective.
And do you use things like, again, so they don't often correlate, having kind of a high PD-L1 status and having KEAP1 and STK11, but if you saw something like that, would that influence any of your practice in terms of reaching from monotherapy or starting with immune therapy by itself, to clarify?
I would, if anytime I see a KRAS STK11 and KEAP1, that really worries me that monotherapy alone is not enough, and I will kind of throw the proverbial kitchen sink at the problem in terms of chemoimmunotherapy, or think about kind of a tailored trial if we have one open at that time.
And then I'm sorry to interrupt.
Just agreeing.
Okay. We always like consensus, but we also like a kind of diversity of opinion, I will say as well. And so I think that, at least internally, I had a moment of celebration when we had immune therapy, kind of a chemotherapy sparing approach that was approved. And there are some patients where, chemotherapy doesn't make sense. And Melina, I want to go back to kind of a point you raised, right? Is 50 really 40 in the optimistic pathologist eye, right? Who knows that 50 matters? And so sometimes I have patients at 40 that I don't think that chemotherapy, they can tolerate chemotherapy. And we do have the approval, right, for any PD-L1 expressing tumor to have certain immune therapies. Are there cases where you might give immune therapy alone for someone who has a low PD-L1 expressing tumor? And for the audience, low would be kind of 1 to 49%.
Yeah, I think that's a great point. The first thing I'll say is that the data for 1 to 49% is not very impressive for immunotherapy by itself. That being said, when you have a patient in front of you that's in that range that you feel that chemotherapy is not the right thing for that person, I have reached for immunotherapy by itself in those patients. And anecdotally, it's worked fine. It's been okay. So, I am a little more of a believer, I guess, in the real world version of that approach than looking at the data itself.
Aparna, any kind of differences in your practice?
So yeah, the data for Keytruda or pembrolizumab in 1 to 49% PD-L1 expression is kind of underwhelming. But I agree with Melina. It's kind of a continuum. There are patients even with low PD-L1 expression who do respond to this. It's just we just need to know. We need to figure out biomarkers or better ways to, figure out who these patients are who may respond. So another thing is, if the patient cannot receive chemotherapy, either because of their performance status or, they may have like poor renal function or for whatever reason or patient preference. If they cannot get immunotherapy, then of course I do use the checkpoint inhibitor. But another interesting thing is, there's some data from preclinical studies from melanoma world, and now maybe even in lung cancer, where, the tumor burden may have something to do with how well patients may respond. So that's another thing I consider. If the tumor burden is low, if it's just a few, mets, then, they may do okay with even if the PD-L1 expression is low. So that's one more thing I keep in mind.
And I want to distinguish, so tumor burden is distinct from tumor mutational burden here, that you're using.
Yes, about
the
volume of tumor, I mean. not tumor mutation, but yeah.
Okay. And then, so what if, what if we turned it around and someone has a PD-L1 negative non-small cell lung cancer? What is your standard approach to treating that? And maybe we can start with you, Adrian.
So PD-L1 dead negative, I really think about clinical trials and also just making sure that they've had comprehensive genomic profiling, no stone has been left unturned, so to speak. But I think this is a population where standard of care would be chemoimmunotherapy, but the reality is that these are going to be stubborn tumors, and that kind of amazing whiz-bang response that we hope for from the immunotherapy component, it's probably not going to come through for most people. And so I think thinking about clinical trials up front is important, and then also kind of down the road. And I'll also often talk with my patients about that reality too, just so that we're starting out on the same page.
And so, Melina, for you, are you still, are you kind of consistent with that practice of thinking about, if you're doing a standard therapy, a combination of chemo immunotherapy, and does histology at all factor into your kind of decision making?
Yeah, so I mean, one thing I've been thinking about recently is squamous patients with squamous cell and PD-L1 negative. There is some data for 2 cycles of chemotherapy with combination immunotherapy that looks maybe a tiny bit more promising than chemo with just one immunotherapy. So it's something I've been thinking about. I would say it's not, part of the way that I think for every patient, but I am considering it for certain patients that I'm particularly worried about or that can't, go on a clinical trial. So it's another option.
And so, and you're referring here to the 9LA study.
Correct.
Where people got the combination of 2 types of immune therapy, so nivolumab and ipilimumab, overlapped with 2 cycles of chemotherapy, kind of based on the premise that when people really look at patients who got either immune therapy by itself or chemotherapy by itself, there's a population of patients who really doesn't benefit very early on. And so, as Adrian has already said, the kitchen sink, so throwing everything at these tumors, hopefully we can salvage or help people in that critical initial time point. And so that's the rationale for kind of regimens like this. One other option is actually the immunotherapy doublet by itself. Are any of you using it, and are there particular contexts where you think it makes sense?
So the dual immune checkpoint blockade. So there was the keynote, what was it, 598? I think those numbers start blurring now. But I think it was keynote 598, where, it was a randomized controlled trial of pembrolizumab monotherapy versus pembro and ipi combination. And that trial had to be stopped for futility because the efficacy and survival are all similar between the 2 arms, but toxicities were so much higher with the dual immune checkpoint therapy. So they had to stop the trial. So I don't use this combination. As that trial, to clarify, that trial was for PD-L1 high, PD-L1 50% or more. It is still FDA approved for 1 to 49%, but I prefer using chemoimmunotherapy. I mean, one, because with dual immune checkpoint blockade, the toxicities are quite severe. I've had patients who ended up with myocarditis, severe colitis, and they cannot get any more checkpoint inhibitors after that. So it just kind of stunts the treatment course. So I think the toxicities are a big put off. So I tend not to use the dual immune checkpoint. But what's interesting is in PD-L1 negative or less than 1%, if you look at the Checkmate, I think it's 227. If you look at both the Checkmate 227 and 9LA, in 227, I don't think it was their primary endpoint to look at survival or anything in survival data in PD-L1 negative patients. But when you look at the analysis, that's the most interesting part of that trial, where the responses seem to be more durable. But I think we have 4-year survival data now, but we need a little bit longer term survival data to see how that turns out. Now with 9LA, again, it's concern of toxicities. Even in that, I think now we have 2-year survival data, if I'm not mistaken. So we need to look at longer term follow-up data and see how patients with squamous cell histology do. That would be interesting to see.
No, I agree. And I think that there's kind of, to me, two key kernels for what you said among, there are multiple more, but there's two that I wanted to kind of focus on. And one is that the enthusiasm around immune therapy versus other therapies is really the durability of response, right? Where we see that tail at the end of the curve and we're thinking we're benefiting people for years. And I think that's great. And I think the other piece that you've highlighted is a toxicity, right? There seems to be this tension between toxicity on these trials and real world toxicity. Because if you look at 227 and those types of trials that did immunotherapy doublets, and then you do the quality of life measures, it seems that the study kind of suggests that people have better quality of life with an immunotherapy doublet versus chemotherapy. But in our real world practice, it's not uncommon for me to hear from my colleagues that that's too toxic. I worry about giving it to this particular patient. And so, Melina, do you mind kind of delving into some of the key toxicities we worry about with these combinations and why we don't mention them as often when we think about Keytruda by itself or kind of Tecentriq or atezolizumab by itself?
Yeah, and this is something we've had to grapple with in the mesothelioma world, in the last year, because we've all of a sudden started giving nivolumab and Yervoy to a lot of mesothelioma patients that are older, and it almost universally causes some sort of toxicity. So it can be mild, but the types of things we look for in particular that are worrisome are colitis, which would manifest as diarrhea, profuse watery diarrhea, pneumonitis, which would manifest as shortness of breath, that's inflammation in the lungs. And then I think probably the most concerning and the one that's most different from, just pembrolizumab alone or nivolumab alone is hepatitis. So inflammation in the liver causing changes in the function of the liver. So those are the ones that I see and worry about the most commonly. But I always tell patients, whenever they start any immunotherapy, I say this can cause inflammation anywhere. So, if you have an old injury in your shoulder, that it can cause inflammation there. So it really can manifest in very strange ways. I'm continuously humbled by immunotherapy.
No, I think it's key, right? And so chemotherapy sparing does not always mean more tolerable. And so I think it's important to kind of get into that discussion. And so I guess another point is that in thinking about, we've talked a lot about disease burden, right? And so in addition to disease burden, sometimes we have to think about disease location. And one particular problematic location is central nervous system metastases, right? Brain mets, the cancer that's kind of penetrated the blood-brain barrier and is now in the brain. When we, in the targeted therapy space, we're fortunate to have multiple pills that penetrate that blood-brain barrier and can really overcome brain metastases. But when we don't have a pill therapy to give, and when we're using immune therapy and chemotherapy or immune therapy by itself, how do you think about kind of the approach to treatment of brain metastases? Are there kind of instances where you would just go with the systemic therapy alone and skip over doing radiation? And maybe we can start with you, Melina, to get your thoughts, and then Adrian can chime in if there's any if there's agreement or if there's any kind of additional nuances you want to highlight.
Yeah, so I think, as you point out, with immunotherapy, I do not rely very heavily on the immunotherapy to help out in the central nervous system. So in the case of brain metastases, the response rate, meaning, the amount that the percentage of time that these areas shrink, is somewhere in the order around 30%. So it's certainly not something to rely on. I rely much more heavily on hopefully very targeted radiation to take care of those areas. Now, if somebody had very small asymptomatic brain metastases, would I give them just a short interval follow-up MRI after starting immunotherapy? Possible, but that's very patient selected, and I don't feel as comfortable when they're on immunotherapy alone or with chemo.
And I agree with that. I think, especially if you have the option for gamma knife or stereotactic radiosurgery, that really makes sense. I think one of the other interesting dimensions too is that giving immunotherapy after the radiation component might actually help it to work better. I mean, from a kind of immune priming perspective. And to come back to the combination immunotherapy question, one of the things that I thought was really interesting about Checkmate 9LA is that inexplicably, the patients who had brain mets seem to do better with combination immunotherapy. And I think that maybe hints at the potential that giving a CTLA-4 inhibitor like ipilimumab or Yervoy after radiation might particularly help with promoting an anti-tumor immune response that I agree is probably not good enough to rely on to control brain metastases, but maybe can prevent CNS progression or recurrence down the road as you continue to treat with immunotherapy. So in my brain mets patients, I often think about using combination immunotherapy for that reason.
No, I think that that's been a very intriguing signal. I think it's been kind of described in melanoma as well. And so that is something that we have to keep an eye on. And so, Parna, any differences in thought around kind of management of brain mets, and how does location, symptoms factor in? Melina mentioned maybe in select cases, if there's small brain mets, you might do a short interval scan and try to skip radiation if you can.
Yeah, so I agree with everything said, but there is actually data that I think there was a trial a few years ago where they looked at doing SRS followed by immunotherapy, and those patients did better than patients who got radiation after they started immunotherapy. So I always have the brain. All of the clinical trials also require that the brain mets are treated. So whatever data you're getting out of these trials for brain mets, it's those patients have been treated before, either with surgery or with radiation. So I follow the same standard. So I send my patients for radiation or surgical resection. So yeah, sometimes there are some occasional cases where you don't know if it's a met or an artifact, and it's kind of confusing, where you kind of get started, get a short interval scan to make sure things are okay. Those are the only situations where I would probably skip radiation, but otherwise, yeah, I agree with what was said.
Yeah, and I think that one other thing that it doesn't come up always, but it comes up kind of often enough, is symptomatic brain metastases, and someone requires steroids, and then how the counterbalance of steroids and immune therapy, and thinking about things like that. And so in our final 5 minutes, I wanted to pivot and talk about, we're continuing the immunotherapy theme, but talking about our patients who have driver alteration. So people who have benefited from targeted therapy, and now there are no more available targeted therapies. Do each of you think that there's a role for immune therapy, kind of brief answer, a role for immune therapy in this population of patients as by itself, or should it be combined with something? Should we be looking beyond checkpoint inhibitors as immune therapy? Then let's start with you, Melina, because you're in the center of my screen. Let's see that.
Great. The short answer is no. The longer answer is yes, with chemotherapy. I think it's very clear that, especially for the most common driver mutations, EGFR and ALK, that immunotherapy by itself does not work. And so I would not ever give someone like that immunotherapy alone. I would combine it with chemotherapy. I will not answer the question about anti-VEGF. I will let the other panelists comment on that.
And one of the things that I always advise, and I think we have to be careful of as a field, is that I think we've turned the idea that patients with targetable mutations don't respond to immunotherapy into a kind of a truism or like a self-fulfilling prophecy. I think they definitely have poorer responses, but I also think we're really just talking about PD-1 inhibitors. And I haven't entirely given up on the possibility that there are immunotherapeutic approaches out there that might work better for EGFR, ALK, or other targetable mutations. That being said, I I am always careful about saying that a given driver is responsive or not responsive to immunotherapy, because I think we really only know that responsiveness is poor, perhaps for EGFR and ALK. And then for other targets like HER2 or things like that, who knows? Definitely not for KRAS. So I agree with the point about thinking about combination chemoimmunotherapy when you go to or reach for that. I'm always a little careful about that, though, because if you're thinking that the patient might be a candidate for TKI rechallenge or a combo TKI trial down the road, then adding on the immunotherapy, unless you're in kind of what you really think is a later line, can increase the chance of toxicity subsequently. And then lastly, I think the idea of VEGF plus PD-1 is an important one. I think we haven't fully explored that. Empower 150 suggested maybe that's a better approach. And we also know that VEGF inhibitors are immunomodulatory. They really affect myeloid-derived suppressor cells. They affect Tregs. They might really be doing something important to the mechanisms that EGFR mutant tumors rely on to evade response to PD-1 inhibitors. So I think that's something that we maybe need to look at more carefully over time. There might be better strategies for these patients.
And Aparna, Doctors Marmarellis and Satcher have left you 30 seconds to distill your answer to this question. So what are your thoughts?
That's going to be so challenging. But yeah, I agree. There are two things when it comes to using immunotherapy, right? One is, is it efficacy and toxicities from if you use immunotherapy in patients with these genomic alterations. I agree that not all genomic alterations are the same. We know about potentially low efficacy in EGFR and ALK, but it's not the case for BRAF. About 50% of patients will probably respond pretty well. Not the case for KRAS, may not be the case even for RET. So, I don't think we should generalize that. But at the same time, toxicity risks are real, especially if you've used immunotherapy and then you want to use TKI. That sequence is problematic. So I think we need to be mindful of that. But in the second line setting, there was some data presented recently at the WCLC conference where chemoimmunotherapy, platinum doublet with Keytruda seems to be efficacious, but it was a single arm, I think a phase 2 trial. So we need to compare that. We know that platinum doublet can work. So we need to see what the contribution of the immune checkpoint inhibitor was. So I think we need trials to figure out who responds.
No, I agree. I think that we should always shy away from dogma. But I think one other key point, just to emphasize in the last kind of few seconds, is that the disease burden, again, location of disease matters, right? If you're still having disease control in the central nervous system, you might be less inclined and less enthusiastic about adding immunotherapy versus continuing the chemo and adding the continuing the targeted therapy and adding chemotherapy. And so with that, I really wanted to just extend again gratitude and thanks to Doctors Marmarellis, Dr. Satcher, and Dr. Hede for this wonderful conversation. I think it was a rich discussion, and as you guys probably have kind of surmised, it could go on forever. But I do think that there's other questions that I have not asked and that are asked in the Q&A panel. And so with that, we're going to turn towards the Q&A component of the program and answer some of your questions. And I encourage you, if other ones come up as we're answering these questions, feel free to input them into the Q&A function. And we're also inviting Jack back for this component and Dr. Shah or Riyaz. Perfect. And so to start with the first questions, one question that hasn't been addressed is there's questions about radiation and kind of palliation of pain and using kind of a cyberknife versus proton radiation for palliation of pain. And then if anyone has any thoughts on kind of adjunctive therapies, acupuncture, etc. And perhaps we can start with Riyaz, because we haven't heard from you in a little.
Yeah, so I mean, in the UK, we do have limitations on access to things like CyberKnife, massive access to protons. Effectively, proton therapy is not available for lung cancer in the UK in any shape or form. I've seen the data on well, let's call it SBRT, stereotactic radiotherapy, better pain control, long-term palliation control. So I get that, but the logistics of delivering that in our system are very difficult. So it's something perhaps maybe in the private sector is used more widely, but 8 gray single fractions of radiotherapy are very standard in the UK for palliation of pain.
And then Adrian, any differences in practices in Canada?
I think we tend to lean more on kind of gamma knife and stereotactic approaches. I think the devil's in the details. Like, it depends a lot on what you're trying to do. And I think if you have a really focal bone metastasis that's symptomatic and you're very worried about it, causing local complications, then a radiosurgical approach really potentially makes sense. I think for other areas where you're just going for pain control, then I think standard fractionated radiotherapy makes a lot of sense. So I think you need to choose the right tool for the task at hand. And I tend to avoid kind of broadly saying like gamma knife's better, or SRS is better, or fractionated radiation is better. I think you have to match the problem to the tool.
Perfect. And so we have a couple of questions about post-osimertinib therapy for people who have EGFR altered lung cancer. And so I wanted to, perhaps we can start with you, Melina, your approach to the post-osimertinib setting, clinical trials, the VEGF inhibitors, et cetera.
Yeah, so I think, this is an area where there are probably a lot of different practices, but I think most of us would agree that kind of the first step is gathering information. So certainly kind of trying to figure out why there might have been resistance to osimertinib, both by getting a liquid biopsy and by getting a biopsy of the soft tissue. And what you're looking for there really are 2 things. The first is a transformation to a different type of lung cancer, which is rare, but happens probably about 10% of the time, where under the pressure of osimertinib, the disease actually changes over to small cell, in which case you treat it like small cell. And the other thing you're looking for are possible resistance mechanisms that could be targeted. So things like alterations in MET, where you might be able to add another targeted therapy to overcome the resistance to osimertinib. So once we have that information, then I consider a variety of systemic options if we're not able to identify, a targeted resistance mechanism, including chemotherapy with bevacizumab, so kind of that anti-VEGF. And then also we have clinical trials looking at targeted therapies such as amivantamab with lazertinib, and there are several other types of those trials kind of looking at target.
Can I ask folks, I think one other important variable is brain control. I think that the central nervous system and Tagrisso osimertinib has really given us an option that makes us prioritize the brain because we now can. And so when a patient has progression after osimertinib, we're reluctant to lose that. And so how often do you all think about continuing osimertinib? Obviously, that means that you really need to deprioritize or avoid immunotherapy for the toxicity. But some people, I think one of the bigger questions, and you all discussed it masterfully, was the arguable questionable role of immunotherapy in patients with a driver mutation. But if you are making a trade-off of CNS control with ongoing EGFR inhibitor, ALK inhibitor, and giving that maybe concurrent with chemo versus trading out for immunotherapy, what are all of your thoughts on this? Because I think it's a big question. Adrian, can I ask you first?
Yeah, I was ready to jump in. I think you have to tailor your approach to the patient, and I think you need to decide at the time of progression what is the biggest threat. Is it the CNS progression? or is it what you are seeing in terms of extra CNS or systemic progression? And I think for patients where I'm really worried about kind of the number of mets they've had in the brain previously, or perhaps if they have leptomeningeal disease, it will be very hard for me to entertain letting go of osimertinib. And often for those patients, I might attempt to kind of ablate whatever might be progressing systemically with radiotherapy or other approaches. And only when I think that their disease outside of the CNS becomes the bigger threat will I then kind of think about letting go of osimertinib or adding on other systemic therapies. I don't think there's a one-size-fits-all approach, but especially for EGFR, the CNS really is such a dangerous site of disease to lose control of.
Perfect. And I see a question here about, I always think that it's a great question about kind of how many genes should we be testing? Do we need 300? How broad is too broad? How broad is broad enough? And so we know that there's kind of diversity in people's in-house panels. Some people use a smaller panel, and Aparna, I heard you mention that a smaller panel, and Riyaz as well in your component of this program, smaller panel is suitable for early stage lung cancer. But how many genes do you think we need to be testing for? Do we need 300 gene panels? And perhaps we can start with you, Narjust, since you just joined us.
Hi, everyone. I'm back. So I'm in the broad category. Like, I don't have the exact number, though. Dr. Dagogo Jack, like 305 is my number to go. But I'm really into it is opportunity to learn about our patients' diseases and to get ahead of the curve in sometimes. Because if you have a patient with EGFR concomitant T53, that you have a very different patient than a patient with EGFR. I think only. So I think it helps us understand. And also, if we don't have broader spectrum, then there is limited about potential early phase clinical trials for these patients, right? All these mutations that started in phase 1, and now we're having trials about STK11 and new mutations are coming along. So the bigger, the better. Is that what would you say?
Can I offer a somewhat opposing view? And that is not to say that we should, plan on what's the least you can get by with. I don't think that's the right mindset, but kind of like, at least for a long time in digital photography, there was this obsession with how many megapixels your camera had, and as if that made you a good photographer. And in truth, I think over time we realized it's both the software and not just the sheer, the sheer hardware of it, but also the talent of the person doing it. And in truth, we have upwards of around 10 targets that are clearly relevant now, and another many that are emerging. But I think I would not want to give people the mindset that if they got a 50 gene panel, that's insufficient, because that covers more than everything that is relevant today and likely everything that's coming on the horizon in the next couple of years. I think TP53, HER2 are not technically, actionable with targeted therapies this minute, at least FDA approved, but they're on every one of these, shorter lists. So if you're in the dozens, I think that's plenty. And I think a lot of what we add, when it's just a numbers game, is white noise. That's my concern, because you did talk very effectively about how the reports are 70, 80, 90 pages and wildly complex. And I think that adding more confusion to it, I'm not sure is, I think it's maybe a U-shaped curve that is counterproductive after the first 50 or 100 and so I don't know, you definitely need enough, but I'm not sure that I wouldn't want the audience to think that if they only got 100, that they're 200 short of what is complete. And I'm going to let my dog out because she hears my wife here. So.
Yeah, this is like a really good point, Jack. I'm always in the fear that NGS is better, so providers don't have to remember every gene, because I have seen when they're individually ordered, increases the chances of human error. And then you're right, we started with one and now we're past that, right? Like, so I think I agree with you, Jack. But my
Well,
fear is that if we do individual testing, somebody gonna miss something.
No, and I think that I agree with you as well. And I think that there are kind of counterpoints to every point, right? And we were all kind of very excited about a brand new fusion described last week or 2 weeks ago. And so will our current test pick that up? Now we have to design. So we always want to be cutting edge, but we also want to make sure that we're serving people now. And I think in current practice, to meet the needs of our patients, I completely agree that a 50 gene, a couple of tens of genes that cover the key biomarkers is suitable. I guess on the subject of complex, can someone chime in? We have a great question here about the difference between a tyrosine kinase inhibitor and the allosteric inhibitors and other types of inhibitors, particularly a KRAS G12C inhibitor, and how that is distinct from our kind of typical targeted therapies that we're used to.
I could jump in on this one. So the reason that KRAS G12C inhibitors are so different from our tyrosine kinase inhibitors is that generally the tyrosine kinase inhibitors work by competing for binding with a molecule called ATP for tyrosine kinases and kind of blocking that binding site. That doesn't work in KRAS because it binds a different molecule called GTP, and it binds it so tightly that you really can't outcompete it. So the G12C inhibitors work in a weird way in that they actually bind to KRAS G12C when it's bound to something called GDP, essentially in its inactive form. So they kind of ambush it when it's inactive and lock it into the inactive state so it can't then bind to that molecule GTP and become active. So the biology is really different. That also creates some interesting externalities as well, because you haven't really fully blocked KRAS in its kind of active state. And so one of the ways that we think that KRAS mutant tumors might become resistant to G12C inhibitors is by just overdriving KRAS signaling. So KRAS isn't really in the inactive state very often. So the biology there is a bit unique. And I think we're seeing some of that come through in the more modest response rates. I think also, though, provides an opportunity for combination therapy to be really effective. So I'm kind of excited to see where we go with this, the unique biology of these new drugs.
And I think that this will become even more complex as we start getting drugs like antibody drug conjugates into the space, bispecific antibodies. So these are excellent questions to ask. And so one other question that I see in the chat here is going back to the concept of liquid biopsies, and these kind of encompass both early stage and kind of advanced stage lung cancer. And so this question gets at both of them. And it's asking the question of minimal residual disease testing, and also in general, the likelihood of a false negative result from a plasma test. And can someone, perhaps we can start with you, Dr. Shah or Riyaz, to speak about kind of whether there are particular contexts where the yield of liquid biopsy may be a bit lower.
Well, I think it's very, so in the UK, liquid biopsy is not widely available at all. But you know, some people, so, you know, it's available, but not perhaps funded. I'm always amazed that you can never really predict who will be a non-shedder. So I've got some patients with really floridly advanced disease whose ctDNA tests have been completely negative. So, I mean, I think we alluded to it earlier in the discussion that actually, I can't remember who said it, but you need both actually. When you have both done, you know you've got the widest kind of reconnaissance mission you've done possible to try and pick up anything. So I think they're not, you know, ideally you would want both done if it was affordable and deliverable.
But I think as a general principle, and you know, Adrian, you've done some of this work. Melina, you've been at a center that has done a ton of this. I mean, there's a few general principles. One is absolutely you can have false negative results. You can't take a negative as the gospel. But the result is much more reliable if it's positive. If it's positive, you can believe it. If it's negative, it could be truly negative or it could be missed, just not the sensitivity there. And there's some correlation. I mean, the yield is higher in patients who have a larger volume. Liver metastases generally are associated with a higher probability of shedding. On the other hand, if you have someone you're concerned about, repeat biopsy, or it's a difficult repeat biopsy because there's just a couple of pleural-based nodules growing from 6 to 7 or 8 millimeters, that's not going to be one that's going to have a high yield for liquid biopsy. Great if you can get it, but you shouldn't bank on it. And that's, I think, a challenge. I think the question also is asking about, particular vendors, and I don't feel as confident, strongly recommending one or another. Guardant has been one of the ones who's produced a lot of the data in this space and is the one that we use, but I wouldn't want to put out an edict that they are what everybody should do. I welcome other comments on this.
Yeah, I'm
I think
the same mindset. I think that we're in a great space where we have multiple different assays that work and that have proven activity. And of course, I think a key point is that the tests that we're accustomed to, the Guardant, Foundation One, et cetera, may not be the reliable test for the early stage setting. And so there are companies developing more sensitive assays for that setting. And I think you highlighted one in your question, like Natera and other companies like that. And I think one question that has come up is specifically how do we manage kind of stage 3 driver mutation positive lung cancer after completion of chemoradiation? We've heard across the board that there is some wariness or apprehension about using, lack of enthusiasm is a better word, about using durvalumab in this setting.
Yeah, I think if people have particular questions about should they do it, I think it's an individualized discussion with the doctor. I mean, many of us, even having carefully reflected on the same data, have somewhat different interpretations, and over time, my own views have evolved. I think it's tough. I would just say that for the reasons that have been enumerated, the data have not looked very compelling for at least some of the driver mutations that like EGFR and ALK that we've looked at a little more, but we shouldn't paint them all with the same brush. And I think that came through in several of the answers, that not all driver mutations should be viewed the same.
Perfect. Let me see if we've hit all the questions. I think that we had most of them covered. And I guess maybe in the final 2 minutes is really going back to the discussion about, I know that there's great work coming out of the UK, out of Asia, out of the US about addition of VEGF inhibitors to EGFR targeted therapies. And I don't know if someone wants to summarize where we are with respect to that. I guess I can just ultimately say that we're still sorting out the answer to the question. There have been multiple studies that have shown, at least so far, that it may be too early to kind of add that to replace our standard. And there are, when we think about VEGF therapies versus targeted therapies, when you're on a pill, you're not coming into the clinic, there's not some of the toxicities associated with infusional therapy. And so the jury's still out on those therapies.
Yeah, I was somebody who years ago, based on very preliminary data, was very encouraged by what came out of Japan, first line combining erlotinib and bevacizumab. What I think we've seen is that has consistently improved disease-free survival, but has failed to change overall survival. And with some added toxicities and being tethered to coming in every few weeks for treatments, has not been broadly adopted. I'm not as impressed by the data limited thus far on VEGF plus osimertinib as, say, chemo plus EGFR TKI. So I think the jury's very much still out on the role of VEGF either first line or in the follow-up setting, and still a lot of questions about whether VEGF improves things with immunotherapy, for instance, so how important that is in the whole mix after osimertinib.
I think I'll add one thing to that, which is that, I think we'll probably get to a place where we are stratifying patients with driver mutations, so, in particular EGFR, and saying this person, is higher risk and may not do as well on osimertinib alone. And whether the tool that we reach for is chemotherapy or anti-VEGF or even a combination, is to be determined. But I think there is a population that we're identifying that really doesn't do quite as well. I need something else.
Perfect. And so with that, I guess we'll conclude with future directions. And again, I wanted to, on behalf of myself and Jack and all of the panelists, I want to thank everyone for tuning in today, for your wonderful questions. And I also want to thank the faculty who gave their time and their expertise today. And again, extend thanks to Takeda for sponsoring this. And kind of in wrapping up, I think it's important to note that to thank each one of you, our patients, the caregivers, for tuning in and becoming really partners in the cancer journey. That's the goal of GRACE, to get patient education out there and to kind of work to collaborate with our patients and our caregivers. I want to say for those of you who want to kind of revisit some of the things we discussed today, this will be posted on the cancergrace.org website in the coming weeks. And again, thank you all for your time and have a happy rest of your Saturday.
Thanks, everyone.